So a lot of the discussions relate to avoiding problems or avoiding complications. So what are these complications, and if they occur, how do we manage those complications? And that's actually the topic for the next couple of lectures that we have with some demonstrations. I think Stefan, you have a pretty impressive case to show what can go wrong if things go wrong, right?
Exactly. So especially in this session, we wanted to focus on the complications. So the complication rate, as you have seen in the studies, is only 2% in the studies from the classical approach. But the question is, what kind of complication we may expect? And we would like to show you a first case. This was a 70-year-old male. He had dysphagia. He had a 4 by 5 centimeter large Zenker's diverticulum. We performed the diverticulotomy, and then after the myotomy, we did endoclipping of the mucosal defect. And I want to show you the final result of this Zenker septotomy. So we didn't cut too deep, and we also, from our impression, perfectly placed the clips. And as I mentioned before, because we also always want to be on the safe side, we clipped the whole area. And after the procedure, we had the impression that that was a perfect endoscopic intervention. The patient was on IV antibiotics. He had no oral intake, and first he had some elevated leukocytes, which normalized after 5 days. Here you can see the laboratory. But then after 5 days, it was somehow, we noted that the CRP level was relatively high. And when we asked the patient about his symptoms, he described that he still feels some remaining fluid in the throat. So we were thinking, before an oral intake will start, we should have a look how is the endoscopic situation. And then we went in with the endoscope, and you will agree with me, we saw a complete disaster. There was no more clip, and in the area of the Zenker septotomy, we entered the mediastinum. Here in the CT, on the left side, you see the diverticulum up, and there is a huge mediastinal abscess crossing to the contralateral side. So what did we do in such a situation? We first called our surgeon, Paul, to assess with us together the situation.
Thank you, Stefan, for inviting me to this convention, and also for this case. We always discuss cases together. Whatever we always discuss. So from a surgeon point of view, just a general comment on esophageal perforation. So if you have a cervical perforation, for whatever reason, you have to call a surgeon, because the cervical area is a very simple area. We have a very easy access through the left side, and of course you have alternatives in any kind of cervical perforation. Sometimes you can do it conservative, sometimes endosponge. I will give you my position in a short period of time, but I want to stress the point that in a perforation you have to call an esophageal surgeon and discuss the case with him. And we have two situations, and we have common rules, we have algorithms in our institution. We worked it out for our hospital, and also the Trimme-Spital, the second, also a large hospital, took it over. And our rules for Zenker perforation, endoscopic perforation, is and it's general rule for perforations. We always have to keep in mind, is it fresh or is it a delayed? Second thing, remember the CT scan, is it contained or is it non-contained? These are the two most important questions. And in Zenker's perforation, there is one more important question I want to focus. So, fresh perforation happened last year. I got a call from the endoscopist in Trimmispital. He said to me, Paul, I just have a perforation of a Zenker's diverticulum. I said, did you perform the myotomy? He said, no, I just started, have the perforation. I said, okay, bring him to the operating room. I will fix the situation. We fix the situation. Is not a problem. If you have a delayed diagnosis or secondary perforation, whatever you will call this, as in this particular case, after several days, 48-hour rule for perforation is already passed. You saw the lesion was a contained lesion. Problematic lesion because you saw already the indulging of the mediastinum in the apex of the rest of the right chest, but contained. So the question is, in this situation, next, of course, that the patient is not septic, is the question to the endoscopist. Did you perform the myotomy? Because we have two ways then. If the myotomy was performed, and Stefan answered to me, for sure, I performed the myotomy. I said, okay, then we can do conservative treatment. In this case, he will show you the treatment. If he would have told me, I did not perform the myotomy, or the myotomy is incomplete, no conservative treatment. We have to go in and fix that. Because if the myotomy is not performed, and you have a hole, you have a high pressure zone, and this will not heal. So this is the important question. Division completed or not? And if it's completed, and if it's contained, you can go for conservative treatment. Maybe just the principles for you is maybe not so much interesting, but in the esophagus in particular, I show it to you here for perforation in the Boerhaaf's position, but it's the same rule applies for the cervical. So the same rule applies for the cervical, but not for Zenker. In a Zenker perforation, you do not suture the muscle because you have as Stefan pointed out in his presentation of the anatomy, you have no circular upper sphincter. It's a very complex sphincter. If you start to suture the muscle, then he will have dysphagia for sure. So you will suture only the mucosa. And as a salvage procedure in very complicated cases, if we have to fix a complicated case delayed, then our first choice is myocutaneous pectoralis pedicle flap, which we successfully used in a few cases with cervical stenosis.
So after we have clearly answered the question that we performed the septotomy, we first placed a PG in this patient, and then we started performing an endoscopic vacuum therapy. Here you can appreciate how we placed the sponge. It is a little bit tricky to place the sponge in this area. And here you see the laboratory follow-up. So after the diagnosis of the leakage and placement of the sponge, you see how the leukocytes and also the CRP decreased to normal value. We performed 7 times an exchange of the sponge, and here you see the follow-up 6 days later, 15 days later, 18 days later, and luckily we could close the defect with this approach. As I mentioned and as Paul mentioned, We had performed the septotomy, and it was a contained lesion, so we were lucky that we could solve the case with this endoscopic vacuum therapy.
Thank you, Stefan. That's an impressive case. Did you, after 6 sponge exchanges, at some point close the defect yourself with clips, or did you have this closed spontaneously?
No, I think after this time makes no sense to use clips to close the defect. I think sometimes you have a small remaining cavity with granulation tissue. In this case, patient may already drink water, but I think then finally this small defect closes by itself.
So you just try to reduce the size of the sponge at every sponge exchange
Yes.
until you can't get
Yes,
the sponge in, right?
You will get to a point where you cannot place a sponge anymore.
Okay, so then if we perforate spontaneously in a patient, you don't know the patient has a Zenker until you've perforated the patient. Do we then need a surgeon that actually has experience in treating Zenker's diverticulum, or is this something every average center surgeon can do, Paul?
No, you need an esophageal surgeon to go into this region because we're talking about the cervical region, right?
Mm-hmm.
You have to be used to it because you have a high risk of recurrent nerve palsy. Otherwise, you have to expose the situation, and you have to expose the anatomy correctly. He has to know, how to deal with a sphincter up there. I'm not sure that a general surgeon knows, the complexity of the upper sphincter. No, you need an esophageal trained surgeon.
Okay, that's an important take-home message. If you're doing an upper GI endoscopy, you perforate the Zenker's diverticulum, take out the scope, think, give the patient antibiotics, and then take up the telephone and transfer your patient to a center where both the endoscopist as well as the surgeon can then make the decision call to proceed to what likely then will be a surgical resection or closure of the mucosal defect and a myotomy, or the additional management with sponges, etc. That also is an important interplay between interventional endoscopy and the surgeon.